Today's topic is meningitis. Meningitis is a serious medical condition characterized by the inflammation of leptomeninges, which is the protective membrane surrounding the brain and the spinal cord. There are three main layers: the dura mater, arachnoid mater, and the pia mater. The arachnoid mater and the pia mater together is known as the leptomeninges. In between the leptomeninges, there's a subarachnoid space which contains the cerebrospinal fluid. The normal amount of cerebrospinal fluid is around 150 milliliters, and it contains glucose, proteins, cells, nutrients, and electrolytes. This is the blood-brain barrier. It's a highly specialized and a selective barrier which is made of endothelial cells of the blood vessels, astrocytes, and basement membrane. This separates the circulating blood from the brain's extracellular fluid, and its primary function is to protect the brain from potentially harmful substances while allowing essential nutrients to pass through. So basically, the blood brain barrier acts as a guard and only sends the good stuff to the brain cells. When an infectious particle crosses this blood brain barrier, they can cause inflammation in the meninges as well as the brain parenchyma. If the inflammation is occurring in the leptomeninges, it's called meningitis, which is the topic for today's video. And if the brain parenchyma is inflamed, it's called encephalitis. Meningoencephalitis is when both meninges and the brain parenchyma are inflamed. Meningitis is acquired by a non-infective or an infective route. Microorganisms reach the meninges by different pathways, either by direct extension from ears, nasopharynx, a cranial injury, or a congenital meningeal defect, or by hematogenous spread, that is via the bloodstream. The non-infective causes of meningeal inflammation include malignant meningitis and intrathecal drugs. Now let's talk about the pathophysiology and the etiology around meningitis. Meningitis can be caused by bacteria, virus, fungi, and parasites. We can divide meningitis into acute meningitis and chronic meningitis. Acute meningitis is generally caused by pyogenic bacteria or virus, and chronic meningitis is usually due to tuberculosis or malignancy. The most common bacterial pathogens causing meningitis are Neisseria meningitidis, Streptococcus pneumoniae, and Haemophilus influenza. These bacteria often enter the central nervous system through the bloodstream. Viral meningitis is usually caused by enterovirus. They can enter the central nervous system via bloodstream or by direct extension from nearby structures. Fungal meningitis is often seen in individuals with compromised immune systems. Fungi can reach the central nervous system through the bloodstream or by direct extension from nearby infected tissues. When these pathogens come into the central nervous system, they trigger an immune response, resulting in a whole bunch of immune cells to be migrated to that affected area. These are neutrophils and lymphocytes. Then, inflammatory mediators like cytokines and chemokines are released, and this causes increased permeability of blood vessels, leading to the leakage of fluid into the central nervous system. The influx of immune cells and fluid into the CNS will lead to increased intracranial pressure. Elevated pressure can compress the brain and affect its functions, potentially leading to neurological symptoms. In acute bacterial meningitis, the pia arachnoid is congested with polymorphs, and they form pus exudates which will organize to form adhesions, and they pick on the cranial nerves. This pus will go and get blocked in the ventricles, and as a result, these patients can have cranial nerve palsies and hydrocephalus. In viral meningitis, there's predominantly a lymphocytic inflammatory CSF reaction without pus formation, polymorphs, or adhesions. So, what are the risk factors for acquiring meningitis? Immunosuppression, CSF shunts or defects, renal or adrenal insufficiency, thalassemia, cystic fibrosis, and crowded living conditions. Now let's talk about the clinical features of meningitis. The most important triad is headache, neck stiffness, and fever. And anyone with high fever may be delirious. In addition to that, these patients can also have photophobia, vomiting, and severe headache. And the patient is irritable and often prefers to lie still. They can also have a non-blanching petechial rash, especially in meningococcal meningitis. We can also see signs like neck stiffness, a positive Kernig sign, and positive Brudinsky sign. When it comes to management, we always have to remember that minutes save lives. Diagnosing meningitis involves a combination of clinical evaluation, laboratory studies, and imaging studies. The mainstream investigation is the lumbar puncture, where we will check the parameters like CSF opening pressure, glucose, proteins, and predominant cells to diagnose the type of organism causing meningitis. In addition to that, we can also do viral PCR for HSV infection, cryptococcal antigen, blood cultures, and CT-MRI if there's a focal neurological sign. If there's a petechial rash, it's diagnosed as meningococcal meningitis until proven otherwise. In here, you don't wait for lumbar puncture and IV antibiotics are started immediately. In other causes of meningitis, lumbar puncture is done unless the patient has contraindications like increased intracranial pressure. So the question is, why don't we do lumbar puncture when there's an increased intracranial pressure? Can you guys guess and drop the answers in the comments? When we are talking about the management, in meningococcal meningitis is diagnosed clinically by the petechial rash and immediate intravenous antibiotics is given along with the blood cultures. Empirical antibiotics like third generation cephalosporins, for example, cefotaxime and ceftriaxone can be given. In patients who are above 50 years old, we can add intravenous ampicillin to cover listeria infection. As an adjunct, immediate high-dose steroids like dexamethasone is given with or before the first dose of antibiotics, and it has shown to reduce the neurological complications in bacterial meningitis. For viral meningitis, supportive therapy is considered. For HSV infection, IV acyclovir can be used to cover it. Local infections should be treated surgically if necessary, and if they have depressed skull fracture or meningeal tears, that should be repaired. When it comes to prophylaxis, meningococcal infection should be notified to the public health authorities and advice should be sought out about immunization and prophylaxis of contacts. Chemoprophylaxis with rifampicin or ciprofloxacin should be offered to all close contacts. Vaccinations can also be done like Men-C, Men-B, pneumococcal, and Hib vaccine. Finally, what are the complications of meningitis? Sensorineural hearing loss or deafness, mental impairment, cerebral edema, raised intracranial pressure, subdural empyema, cranial nerve palsy, coma, and death. And that's all about meningitis. I hope you guys enjoyed today's video. Thank you for watching. I'll see you on the next video.